Good evening. Today is the first Pan-Arab seminar where all Arab countries are involved in it. Uh, I'd like to introduce the speakers. We have excellent speakers today. The first speaker is the seminar is in collaboration with the European Society of Neuroradiology and the Egyptian Society of Neuroradiology and Nuclear Medicine and the Egyptian Society of Neuroradiology, Neuroradiology, and Nuclear Medicine. The first talk will be by Professor Tariq Yusri. Professor Tariq Yusri is Professor of Neuroradiology at the UCL, Institute of Neurology and Department of Neuroradiology, National Health for Neurology and Neurosurgery. He is also the president of the European Society of Neuroradiology. That's it. The lecture that Professor Tariq Yusri will be giving is paraneoplastic encephalopathy.
Thank you very much for the kind introduction, and good evening from London, and my best regards from the European Society of Neuroradiology. Delighted that we were able to start this collaboration with PAARS, with the Pan-Arab Society. So that's excellent news. In the meantime, I'm now the PAARS president since September, but I'm also the chair of the European Board of Neuroradiology. Having said that, I will just start with sharing and seeing. Oops. So let me just. Okay. Am I sharing?
Yes.
Perfect. Thank you very much. So first, to acknowledge the help and support over the years from my colleagues and collaborators, Professor Yeager and Dr. Chandrasekhar from our department in London, and there are no conflict of interest related to this subject. So over the next half hour or so, I'll be starting on, with respect to paraneoplastic encephalitis, to discuss with you some definitions, and then moving on to the specific pictures of paraneoplastic encephalitis, and that's the limbic encephalitis and NMDAR encephalitis, to which I will be coming later. So first, some definitions. Encephalopathy, and what do we mean by that? The word encephalopathy means that there is an altered mental state for longer than 20. The patient is characterized by being irritable, showing signs of lethargy, and changes in personality and/or behavior. So that's a picture of an encephalopathy. Encephalitis is a pathological term in which the patient has an encephalopathy, which we have just defined, and then evidence of CNS inflammation and or infection, and at least 2 of these 4 need to be present. So fever, seizures, CSF pleocytosis, and EEG abnormalities. Most likely, this is an autoimmune pathology, but it can also be infectious. It's more likely to be autoimmune than infectious, but both are, of course, possible. Diagnostic criteria were developed for definite autoimmune encephalitis, and all of these must be fulfilled. So subacute onset, which means less than 3 months, of working memory deficits, psychiatric symptoms, bilateral brain abnormalities on MR, and reasonable exclusion of alternative causes. So a mixture of clinical presentation, characteristics of MR, and the logical thing that was almost all criteria that you need to think about differential diagnosis. So all these 3 must be fulfilled, and one of those 2, so either on the CSF, we see evidence of pleocytosis, or on EEG, we have certain waves, certain changes that would be typical for an encephalitis. So we just talked about here about encephalitis, autoimmune encephalitis. So what about paraneoplastic encephalitis? The definition is that it is part of a paraneoplastic neurologic syndromes. It is a heterogeneous disease, autoimmune in origin, occurring in the context of non-nervous system cancer. So something outside of the CNS. The definition of the paraneoplastic syndrome, PNS from now onwards, is that we have a neurological disorder which affects any part of the central or peripheral nervous system, often presenting with typical stereotyped clinical manifestations. It occurs in association with cancer, has an immune-mediated pathogenesis, and frequently we have the presence of very specific neuronal antibodies. Frequent because not always, and the reason is that they have probably not have been identified in those where they're absent. What about the frequency? The prevalence is around 5.4 per 100,000, but if you go to above 60, then it doubles. If you look at cancer patients, then it's much higher, and over the last years, it has increased. The incidence has doubled over the last years. The most frequent tumors are small cell lung carcinoma, of which 10% of those patients present actually with a paraneoplastic syndrome, breast, ovaries, and testicles. The immune response against antigens is expressed either by the tumor cells themselves or by the host nervous system. So we can have the two options. Either the whole picture comes because the tumors produce those antigen, or because the body, in this case, the nervous system, produces them. When does a paraneoplastic syndrome occur? It can occur before the tumor is detected. In those cases, usually the tumor is identified within 2 years, and almost 100% or 90% within 5 years. It can also happen after the diagnosis of a tumor or when a tumor relapses. So the patient presents at the beginning with a tumor without a paraneoplastic neurologic syndrome, is treated, is stable, but then get a relapse of the tumor, and then we get the paraneoplastic syndrome. There are typical phenotypes, clinical phenotypes for paraneoplastic syndromes. The clinical presentation is usually subacute, that means 6 to 12 weeks, as we said, less than 3 months, and it's usually rapidly progressive, but not rapidly progressive in terms of hours or days. This is why the word subacute. There are typically high-risk phenotypes, so phenotypes where the chances of the patients having a paraneoplastic syndrome are quite high, such as encephalomyelitis, limbic encephalitis, Lambert-Eaton syndrome, just to mention a few. There are other intermediate risk presentations like brainstem or stiff person spectrum disorders, syndromes. If you look and come from the antibody side, well, we have antibodies. If we find them, they're associated with a low risk of developing cancer. That means less than 30%, such as GFAP, and I come to that completely at the end, or indeed also aquaporin 4. And you probably know that aquaporin 4 is a hallmark of neuromyelitis optica spectrum disorder, but in certain cases, this can be a sign for adenocarcinomas, associated with adenocarcinomas, but it's quite rare. So that's not the first thing we'd be thinking of. As I said, this is low-risk antibodies. Intermediate risk antibodies, so defined between 30 and 70%, where we have to be much alert if a neurologist comes and says the patient has, for instance, AMPA, the chances of finding a cancer with limbic encephalitis is larger than 50%. NMDR, it's about 40%. So this is the patient comes with a certain phenotype, you find this antibody, and then it needs to click that this is related to cancer, we have to look for the cancer. High risk, more than 70%. Again, a list. We don't need to know all of them. It's not possible, but we need to know that there is an association. So here, for instance, the WHO antibody, more than 85%, we have here diseases with 90% or more than 90% of association with cancer. From this, because it's complex, a score was developed, the PNS care score. It should give you an indication of the diagnostic certainty, and it's based on 3 levels. It's based on the level of risk of the neurological phenotype. We mentioned that before, I mention it again. The kind of antibodies you found and the kind of cancer that might be there. So again, clinical level, we talked about high-risk phenotypes, intermediate or not defined. Lab levels, so what I mentioned, high-risk, intermediate, and low-risk antibody, and then whether the cancer has been found or has been not found, but found on follow-up, or has not been found on follow-up. With each of these, you give a number, and that number can be 3, 2, or 0. And from this altogether, you come to a score. If the score is above 8, it's definite. If it is 3 or less, it's not PNS. As an example, the patient, 70-year-old man, he is on treatment for multiple myelomas and presents with persistent seizures and a prolonged encephalopathy. The MR was done, and you see here some T2 changes. This is not very specific. But you see here on the flare that there are changes of the cortex in the thalamus, and also here in the region of the parahippocampal gyrus. Go higher up on the diffusion, you see again the cortex is involved, and further down here in the region of the occipital lobe and the insula, the cortex is involved. So all this together, because of the involvement of the hippocampus and the parahippocampal gyrus, this is also called the limbic encephalitis. So what about limbic encephalitis? Encephalitis, so of course, it's an inflammatory process, as we said at the beginning. It was quite rare as a paraneoplastic syndrome until the 1960s, when it was first described. The 1980s, the so-called onconeural antibodies were identified, and then one began to see them more frequently. In 2000, there was the cell surface antibodies, and the LGI1LE limbic encephalitis is the most common autoimmune encephalitis. So the limbic encephalitis is associated with, well, if you find onconeural antibodies, quite frequently, you will find a tumor. If it is a surface antibody, you will often not find a tumor. If you don't have an antibody, if there's no known antibody, then quite frequently you will have a tumor. It is just that science didn't move yet at identifying those antibodies. So again, specifically about limbic encephalitis, you will find that ovarian teratoma, Hodgkin lymphoma, thymoma quite often have very specific antibodies with which they are associated. And again, here you see the percentage of finding a tumor to tumor frequencies between 40 and 60% is lower with the other antibodies. Here we are in the region of 90%. You remember that I had mentioned WHO before for the small cell lung cancer. Let's go to another patient. 52 man with drowsiness, memory impairment, and diplopia. The patient did not improve when given intravenous immunoglobulins. And on the MR, you see here some enhancements. You see here the changes, also in the region of the hippocampus and the parahippocampal gyrus. Here you see it nicely within the region of the hippocampus on the sagittal images. So that's a flare, but here you see the enhancements. So that is, again, a limbic encephalitis because the limbic structures are involved, in this case, again, the hippocampus. So what happened after 6 months, you have a partial resolution of the changes on a T2 and flare. On a PET, you see here an uptake, and the uptake showed was located in the tonsil. So we have a left tonsillar mass, which turned out to be squamous cell carcinoma. The thing is, once the diagnosis has been made, or it is suspicious of limbic encephalitis, paraneoplastic syndrome, and supported by antibodies, then everything needs to be done to try to identify the cancer. Another patient, 50-year-old man with a history of chronic alcoholism. He had 2 months of progressive ataxia and right hemiparesis. He had a certain antibody, which is called SOX1. It was weakly positive, and the PET-CT was negative. But then the close follow-up was done because the neurologist thought, this is not right. I want to be sure whether that can be a paraneoplastic syndrome or not. So you see here changes in the region of the medulla, the olive, very specific. Hippocampus, here in the hippocampus and slightly superior to it, so to the amygdala, and there is also enhancement. As I said, the first time they didn't find anything on the PET-CT, and you see obviously the change is much better on the FLAIR images, and you see it's along, it goes from the front to the back, and there is a bit of an uptake in the FDG PET, but most importantly in the testicles. So this was a testicular geminoma, and there are some retroperitoneal nodes. You see here. So you see the clinical presentation, the antibody, weak positive, not sure. First examination on PET didn't show anything. The MR of the brain does show things directing limbic encephalitis. Although they didn't find the tumor the first time, they do another investigation a bit later to find the tumor. So that was around the limbic encephalitis. So let's go to another encephalitis, which is the anti-NMDAR encephalitis. It is relatively new, less than 20 years, if you look at about the limbic encephalitis, first described 2005. The thing here, it is usually associated to psychiatric symptoms. And NMDAR is the second most common cause of autoimmune encephalitis, and 80% improve after immunotherapy or tumor removal. Again, the importance of finding the tumor. What do we see on MR? Well, in more than 50%, we don't see anything. This is important to know why. Because if you get a request and they say, we suspect encephalitis, you can only say there's no evidence. You cannot exclude an encephalitis. It's just not possible because you have to know there are encephalitis which are associated with the normal MR. But in less than 50%, you find changes. Focusing on the hippocampus, as I mentioned earlier, you see here again hyperintensity, cortex, also the cord can be involved, and the meninges can enhance as well as the cortex. NMDR encephalitis are most frequently found in women. A good proportion in are less than 18-year-olds. In a huge percentage, in almost 40%, we find a tumor, mostly in women. It's most often an ovarian teratoma. It has especially high frequency of teratomas in members of the Asian population. Diagnostic criteria again. The first criterion is clinical. We said encephalopathy, so rapid onset, but less than 3 months, and you need to have 4 of these 6 present. They're all clinical, as we said. So certain behavior or cognitive dysfunction, speech dysfunction, seizures, movement disorders, decreased level of consciousness, autonomic dysfunction. You see, it's quite heterogeneous and quite broad. There are a lot of things. It's difficult for the neurologist to make here just on this the diagnosis, but he needs to have 4 of the 6. And then comes the second thing, which is at least one of the following: an abnormal EEG or CSF. Again, CSF is not very specific, of course. And the third criterion is exclusion of other disorders, something I had mentioned before and always comes up again. So all three criteria need to be fulfilled to say we have probably anti-NMDR encephalitis. The first episode of a psychosis, now the other way around. So patients presenting with a psychosis have in 3 to 4% an antibody of NMDR. So have an anti-NMDR encephalitis. And unfortunately, there's no difference between those patients presenting or those patients having the antibodies, so having the encephalitis, from those who are negative. And therefore, some people say that any patient who presents psychiatric syndromes with a psychosis should get such a test. Now, of course, that would have massive implications in terms of testing availability and costs. I'll come to another one. So that is the GFIP specific immunoglobulin, which can cause a very distinctive autoimmune encephalomyelitis. The presentation is headache, subacute encephalopathy, optic papillitis, also tremor or ataxia. It is usually responsive to steroids, paraneoplastic because a tumor can be found over 3 years in about 40%, and a number of tumors can cause this encephalitis. On MR, we see diffuse T2 abnormalities. I'll show that to you in a second. The radial periventricular enhancement, leptomeningeal enhancement, and also spinal changes can be seen. And you see here the percentages. So that's a very typical picture, to have these radial perpendicular enhancements. Also here, the hyperintensity is a long segment of the cord, which can also show some enhancement in the center of the cords. We often find a limbic encephalitis picture. So limbic structures being involved. You can have T2 a signal abnormality and contrast enhancement. Outside of the limbic structures, it's quite variable. You can have what I just showed you, the linear radial changes, multilobar deep white matter lesions, which are of course non-specific, not very helpful, and sometimes there's nothing outside. In the cords, as I mentioned, T2 hyperintensity and cord enhancement, it's however normal 50%, but also you can have changes at the peripheral nervous system. You can have nerve root enhancement. In about 1/3 of the patient, you have actually a myeloneuropathy. Excuse me. And it can be normal. Muscles can also be involved. So keep in mind, this does not need to be restricted to the CNS or PNS. So to summarize, paraneoplastic encephalitis, there's an increasing incidence and prevalence. So we need to be aware about this. It is critical, if you have such a diagnosis, to search for the tumors, because the patient will improve. The tumor might not be known, so to find it will at least enable us to treat the tumor, but also the paraneoplastic syndrome and the encephalitis will improve. What do we find? We are radiologists and neuroradiologists, changes within the limbic areas. We may not find anything. Specific pictures like NMDR encephalitis, frequently associated with tumors, psychiatric presentation not to forget. But the most important thing is to think about it, to consider it, and not to exclude it. With that, thank you very much.
Thank you, Professor Tara Yusri. An excellent speech and a lot of new information. It was pointed out to me that I didn't introduce myself. I'm Professor Rashad Hamdi, Cairo University, Neuroradiology Department. And I'm president of the Egyptian Society of Neuroradiology. The next speaker is Professor Ihab Reda, head of the Neuroradiology Department in Cairo Alexandria University. And his talk will be about MR spectroscopy and T2 perfusion. producing brain lesions.
Thank you, Dr. Rashad, for your introduction. Thank you for organizing committee. I am enjoyed to be with Dr. Tariq Yusri in the same panel. In fact, it is very difficult to present a lecture after Dr. Tariq Yusri, but I'll do all my effort not to be boring. Our topic today will be about MR spectroscopy and perfusion in brain lesions. In fact, spectroscopy is some sort of in vivo evaluation of the metabolites. In spectroscopy, we are aiming to differentiate whether this is neoplastic or not, to differentiate between the neoplasm, the tumor, and encephalitis, post-irradiation necrosis, TDL, granulomas. And if we consider a tumor, we want to know if this is a primary or secondary, and if primary, whether it is a high or low grade. Some other subsidiary uses are in epilepsy and Alzheimer, but they are really not of great importance. Now, in spectroscopy, we are usually we put an ROI on the lesion. If we are using a single ROI, it will be a single voxel sequence. If you are using multiple voxels to engulf the whole area of the tumor or the mass and surrounding area, it will be multi-voxel technique. Each of these sequences will take about 5 to 7 minutes. And then we will get this type of spectrum where the y-axis will represent the amplitude, while the x-axis will represent the location or the site of the metabolites. Each metabolites has its own constant site. This is rated on parts per million. Parts per million is used for substances which are of very low concentration, so that we will have the NAA at 2 parts per million, and creatine at 3 parts, and choline at 3.2. These are the 3 major metabolites that we can evaluate in long TE sequences. I mean by long TE of 135 millisecond. There are other less important metabolites, like at 1 we have the amino acids, 1.3 we have the lipids, lactates, and 1.5 we have alanine, 1.9 acetate, 2.2 we have glutamate, 2.4 succinate, and 3.4 we have taurine, 3.5 we have myoinositol. For these low amplitude metabolites, we are using another type of sequence, short TE sequence, and which about a TE of 35. Now, what does NAA means? The NAA, N-acetyl aspartate, is a neuronal marker. Neuronal marker, I mean that if the neurons or axons are destroyed, the NAA will be of lower concentration. Also in lesions like meningioma, where there are no neurons, we can expect that the NAA can be depleted. What about choline? Choline is related to the choline compounds in the cell wall, so that when there are multiple cell or division, more division of the cells, like in tumor, the choline will be raised. What about creatine? Creatine is related to the energy system of the cell, so that it is more or less stable. In normal spectrum, we can see that the choline is the lower one and the NAA is the higher one. And we can see that if we draw a line, it will be an ascending line. Now, we are not using the height to measure the metabolites. We are using what we call the integral. What is the integral? The integral is the surface of that triangle under the peak. So we are using integral. And usually we are using ratios, not the integral itself, ratio between NAA creatine, ratio between NAA choline, choline creatine, and etc. You can see that this is an example of the normal spectrum, where choline is the lower one and NAA is the higher one. And if we join them, it will be an ascending limb. On the contrary, in an abnormal pattern, we can see that the choline is very high, the NAA is low, and if we join them, it will be a descending limb. This pattern is abnormal. It is not specific for tumors only. It can be seen in infarction, can be seen in granulomas, it can be seen in demyelinating lesion, but with different levels. Now, as we have said that we are using the ratios as markers for the diagnosis. In fact, I give you just a very broad guidelines to use these ratios. Now, how can I differentiate between neoplastic and non-neoplastic? Just look to the choline creatine. If more than 1.8, it is likely to be neoplastic. Look to the N-acetyl aspartate choline. If less than 0.6, it is likely to be neoplastic. Now, if choline creatine is more than 2 or more than 2.2, it is likely to be a high-grade tumor. If minoxidil creatine is of low value, likely to be a high-grade tumor. If of higher value, it's likely to be of low-grade tumor. I want to warn you that sometimes the results are contradictory. I mean that choline creatine more than 1.8, while NAA choline, it may be also more than 0.6. Here denoting to be neoplasm, and here denoting to be non-neoplastic. This can occur, rarely, but can occur. In this condition, you have to rely on your experience. As anything in medicine, no substitute for experience. Now, another entity, how to differentiate recurrence and irradiation necrosis, look to choline creatine and choline NAA. If more than 1.8, this is likely to be tumor recurrence. Again, to differentiate between primary tumor and deposit. In the primary tumor, usually there is infiltration of the perilesional region, so that choline NAA is more than 1. While in deposit, there is no infiltration of such lesion, of such surrounding area. So on surrounding deposit, never we can get this choline NAA more than 1. Okay, let's apply in different cases. The first case, a male with 21 years old with fits. Now we can see that there is in the left posterior central gyrus, you can see there is swollen gyrus, hyperintense in flare, hypointense on T1, slightly iso-intense but swollen on T2. We can see that there is as if there is a vein in it, non-enhancing. There is a rim of hyperintensity descending till reaching the ventricle. So what do you consider? Is it a low-grade glioma? Is it a demyelination? Is it a granuloma? What do you think? Is it a cortical dysplasia? I don't think that we have to go to biopsy. It is an eloquent area of the cortex. Just proceed to spectroscopy. What do you have here? We can see that the spectrum is totally normal. I see that the choline creatine is 0.9, so 0.8, less than 1.8, so it is non-neoplastic. And again, the diagnosis will be cortical dysplasia. Another example, 20 years old female with epilepsy. You can see that there is a hyperintense signal in the pre-central gyrus, hyperintense on flare, hyperintense on T2, iso-intense on T1, no diffusion restriction, and no contrast enhancement. So that is this a glioma? Again, this is an eloquent area in the cortex. We cannot do biopsy without being really sure that there is something aggressive. Now, with the spectroscopy, we can find that the choline creatine is 0.9, is a normal spectrum, non-neoplastic. And if we are doing perfusion, in perfusion, we can compare the normal site with the abnormal site. With the passage of contrast, there is drop of the signal, which is normal, while here in the abnormal site, we can see there is no drop of the signal, and in the color map, there is no color, so it is a hypoperfused. Hypoperfused, non-neoplastic on the spectroscopy, so it is not an aggressive process. with follow-up, the lesion disappeared, so it was just post-ictal and it wasn't a tumor. Another patient, male, 75 years old with headache. You can see that there is edema in the left temporal lobe with a mass along the temporal pole, hyperintense on T2, hypointense on T1. We can see heterogeneous hyperintense on T2 with minimal blooming in the mass. We can see there is a contrast enhancement, irregular enhancement, with overlying meningeal enhancement and with a moderate diffusion restriction. So what do you suspect? Is it encephalitis or it is a glioma? Difficult to differentiate on conventional MRI. Let us proceed to the spectroscopy. In this condition, we find that NAA choline with more than 0.6, and we can see that choline creatine is 1.9. This is one, and we consider here that it is non-neoplastic, and doing the perfusion, we can see that the lesion is hypoperfused in comparison to the normal site. Hypoperfusion, non-neoplastic, it is herpetic encephalitis and not a tumor. Another case, male, 61-year-old, confusion, headache in 3 months. You can see here that there is a lesion involving both hippocampi, extending to involve the inferior part of both frontal lobe, reaching the basal ganglia, reaching the insula. There is no blooming, mild diffusion restriction. Here we can see the asymmetric involvement of both temporal lobes. And again, there is no contrast enhancement at all. The lesion is isoperfused. So now, whether this is encephalitis or a tumor, let us think, if it was encephalitis, it may be hypoperfused rather than isoperfused. What about the spectroscopy? We can see that this ratio NAA choline is less than 0.6, it is 0.3, so that this is in favor of neoplasm. Let us see the short TE. We can see that the myonositol is very high. Again, high myonositol, bilateral cerebral involvement, more than one lobe, neoplastic pattern. We can see, can diagnose gliomatosis cerebri. This is the old name, and proven later on by biopsy. Another case, female, 51 years old with subacute left hemiparesis. Can see that there is a lesion, ill-defined lesion along the left, right frontoparietal high region, cortical, subcortical, and deep, heterogeneous on T2, heterogeneous on T1, areas of hypointensity. And we can see that there is blooming, definite blooming, areas of diffusion restriction. After contrast administration, we can see that there is a ring enhancement, solid areas of enhancement. And again, we're confronted with situation. Is this a mass due to tumor, mass due to encephalitis, or it is a hemorrhagic infarction? Let us see the spectroscopy. We can see that the choline creatine is 1.2. It is not in favor of neoplasm. Choline, NA choline is more than 0.6. So we have lactates. So that this is non-neoplastic. It is an atypical hemorrhagic infarction. And we can see here that the carotid, cavernous portion of the right internal carotid artery shows lacks the normal signal void in the corona as well in the axial, which confirmed the ischemic nature of the lesion. Another patient, female, 70-year-old age, cancer breast with headache. We can see that this patient with cancer breast has a lesion well-defined in the left basal ganglia, left corona radiata, hyper-intense on T2 with a hypo-intense rim, grade 1 perifocal edema. On T1, we can see that there is hyper-intense signal, perhaps due to hemorrhagic product or due to calcification, blooming on SW, focus of diffusion restriction in eccentric location. Following contrast administration, we can see that there is marginal enhancement, maybe part of solid enhancement with a bilobulated appearance. Again, is this hemorrhagic deposit or is it a granuloma? What do you suggest? So that we have to proceed to other entity, we have to do spectroscopy. And again, here we can see that the choline creatine ratio is very low, 0.9, far less than 1.8. And again, it is hypoperfused, so that it is non-neoplastic and to be proved to be granuloma rather than the hemorrhagic deposit, which was supposed. Another case, male with 44 years old with subacute left hemiparesis. Can see that there is a cystic lesion in the right frontal lobe, simulating like fluid signal in flare, in T2, in T1, and we can, with a rim grade 1 perifocal edema, whether this is cystic neoplasm or of parasitic needle, we can't know. Let us see after the contrast. You can see that there is a rim of enhancement around the lesion, and we can see a rim of diffusion restriction and focus of blooming. So that again, whether this inflammatory parasitic or is it neoplasm. Let us proceed to spectroscopy, and we can see that the choline creatine here is 1.8, more than 1.84, and NA choline 0.5. So again, suggestive of neoplasm. Also, we can see on the color map of the relative blood volume that there is a hyperperfused rim. Together points to that this is a tumor. This cystic tumor can be a cystic neoplasm, cystic astrocytoma, or maybe also cystic deposit. We have to interrogate all the area around it to see what about the choline NAA. The choline NAA here was 0.8, less than 1. So, and it was uniformly around the lesion. So there is no peritumoral infiltration. So it is, this proved to be a tumor, more to be a secondary or deposit than being a primary, and proved later on to be a deposit from cancer lung. Another patient, male, 55 years old, with gradual left hemiparesis and known to have a cancer lung. We have a lesion along the right corona radiata. This lesion is surrounded with grade 2-3 edema, compressing the ventricle, facing the sulci, and showing minimal diffusion restriction on its periphery, and showing the thick ring of enhancement. So whether this is neoplastic, yes or no, we can see now that with choline creatine ratio 4, far more than 2.2, it is a high-grade neoplasm. But whether primary or secondary, whether it is primary or single deposit from the cancer lung, is another question. Again, we have to interrogate the area all around the tumor, and which was proven to be choline NAA 0.8, less than 1, So there is no peritumoral infiltration. It is not a primary tumor. It is a deposit. It is, in fact, single deposit. And again, single deposit, single sizable deposit, it's not usually a comfortable diagnosis for the radiologist. Another patient, male, 38 years old, coming with non-Hodgkin lymphoma. Known patient with non-Hodgkin lymphoma coming with recent decreased vision. We can see here that there is hyperintense signal along the left side of the splenium of the corpus callosum, along the peritribunal white matter. It is iso-intense on T1. It is shows no contrast enhancement. We can see that there is no diffusion restriction, and if there is a central vein sign in the SW, so whether this is lymphoma or demyelinating lesion. Coming with spectroscopy, we can see that NAA choline is 0.9, so more than 0.6, so it is non-neoplastic, and we can see that it is hypoperfused, again, non-neoplastic. But here, there is a contradiction. Choline creatine is 1.85, more than 1.8. Here is the contradiction. Sometimes choline creatine is not in harmony with the other ratios. Which one to believe? Now, believe your conventional, believe to the perfusion, and in this condition, we consider it a non-neoplastic and to be a demyelinating lesion, not lymphoma. Male, 70 years old with treated lymphoma and recent headache. You can see that there is some sort of central atrophy, and we have an extraaxial mass, hyperintense on the flare, hypointense on T2, nearly iso-intense or slightly hypointense on T1. Following contrast administration, there is enhancement, homogeneous enhancement with thin dural tails and showing diffusion restrictions. So whether this is lymphoma, it is a lymphomatous deposit, or it is a meningioma. Again, let's proceed. We can see here by the spectroscopy that choline creatine is very high, is 5, denoting that it is neoplastic. But look here to the N-acetylate aspartate. It is more than creatine, denoting that it is not depleted. We have said that in meningioma, usually N-acetyl aspartate is depleted. So this is against meningioma. And for the perfusion, we can see that this lesion is hypoperfused in comparison to the contralateral side. Some types of lymphoma shows hypoperfusion, and others show hyperperfusion. So that in the gathering the data together, this was a lymphomatous infiltration and not a meningioma. Another case, interesting case, male, 56 years old, operated for glioblastoma and receiving radio and chemotherapy. Coming back for follow-up, we can see that there is a large area in the temporal lobe showing grade 3 vasogenic edema and a lesion along the cortical subcortical area at the operative bed at the posterior temporal lobe, complex lesion on T2, complex lesion on T1. Following contrast administration, there is extensive area of enhancement exhibiting all cystic areas, solid areas, ring enhancement, all patterns of enhancement are seen in this area with the mass effect. And there is definite blooming in the operative bed. So what is this lesion? Is it radionecrosis or is it recurrence? Let us proceed to spectroscopy. Performing spectroscopy along the lesion, we can see that choline creatine is just 1.5. So this 1.5 denote that it is irradiation necrosis. And this is along the part of the lesion. But we have to interrogate and evaluate all the lesion, its medial and lateral aspect. Moving more medially, we can see that this part of the lesion shows that choline creatine is very high. It's 3, denoting that it is recurrence. And even the perfusion, that it is hyperperfused in comparison to the other side. So that we can diagnose that there is definite recurrence medially along the peritrigonal region, while on the outer aspect, it was a mere just radionecrosis. This association between radionecrosis and recurrence is very common to be seen. And this is an advantage of the spectroscopy over biopsy, because biopsy will take from only one area, while on spectroscopy, we can examine the whole area. And this is the map of the choline creatine. We can see that this area near the trigone, it shows high values of choline creatine, 2.7, 3.8, while on the outer aspect, on the lateral aspect, the values are very minimal, 1.1, 1.5, denoting that these are radiation necrosis and not recurrence on the lateral aspect. This is the last case, male 17 years old coming for fits and suggested to have mesial temporal lobe sclerosis. And we want to know which side is the abnormal one. On the coronal T2, we can see that there is perhaps minimal thinning of the hippocampus bilaterally. On the coronal oblique flare, thin cuts, we can see that there is thinning of the hippocampus on the left and on the right side, perhaps more on the right side. But which side is responsible for that epilepsy? Performing spectroscopy and searching for this amount, this NAA divided by the sum of choline and creatine. And we are measuring that on the left side, the left hippocampus, and on the right hippocampus. And on the hippocampus anteriorly and posteriorly, while on the middle parts of the hippocampus, it usually gives us equivocal results. On the left side, the result was 0.6, while on the right side, it was 0.8. So it was obvious that the left side is the offending side. Remember that things in nature are never to be straightforward. Look, so that never to rely on spectroscopy alone without the conventional data. Look for that example. You can see for that example, this curve, the choline creatine is nearly 3. The NAA creatine, it is about, NAA choline is 0.1 or 0.2. It is a typical neoplastic pattern, but look for the conventional. This is a classical case of Adams. So I've told you that abnormal spectroscopic spectrum are not specific for tumors. They can be in demyelinating lesion, can be in granuloma, can be in infarction, can be in encephalitis. And it is the whole data gathered together, you can reach the diagnosis. So returning home, your take-home messages will be that you have to believe in your conventional data, believe in the differential diagnosis list that you can get from the conventional films. And then from these differential diagnosis list, you have to choose by the spectroscopy. The spectroscopy will just choose the optimum diagnosis from this diagnostic list. Spectroscopy will not invent a diagnosis. It just will choose from your diagnostic list. Always use spectroscopy with diffusion and with perfusion. Only do it all together as a package. Never use spectroscopy for diagnosis alone, just always with diffusion and perfusion. This will markedly increase the accuracy. When there are hemorrhagic blood products, this will markedly degrade the wave quality. Also, when we are near the bone, near the calvarium, this will degrade the wave quality. Perhaps in this condition, we can use a single voxel technique, but sometimes these are the limitation of the technique, and in these conditions, perhaps the spectroscopy will have no value, and we can play it down and become obsolete in these conditions. This was my end, and I thank you very much.
Thank you, Professor Ihab, for this excellent and beautiful images and this huge collection of images. Unfortunately, we have not received any questions from the panel. So I'll ask a question to Professor Ihab.
Yes.
We started with spectroscopy in the early days And we tried to differentiate between a post-operative malignant tumor, and there was some enhancement on the edge. And we always had a problem with differentiating between malignant and granulomatous, post-operative granuloma. How accurate is spectroscopy? I mean, if you take it percentage-wise.
Nothing is 100%, even
Yeah,
biopsy, because he can take the biopsy from an area of radiation necrosis while the tumor is just beneath it, a recurrent tumor.
that's true.
But I think it's in my own experience, perhaps we may reach 80 or 85 level of sensitivity. But perhaps we can ask Dr. Tariq Kusri about his experience about that.
Well, thank you very much, yes, for turning the question to me. So this is this is of course a very difficult field, and as you said, even the biopsy is difficult. So I had quite a number of cases where the pathology comes back. When they do pathology, the pathology comes back and say it's a mixture. We have both necrosis and viable tumor cells.
Exactly.
And then,
this is the common situation.
Common situation that they have both, and then we don't know what to do. And then usually the oncologist, they go by a combination of the overall situation of the patient. Is the patient okay? Is it stable? Or is there any clinical signs of progression? And they go by this. But I think it's a very difficult area. So we do like you. We do both perfusion and spectroscopy. But as you said, Dr. Ehab, we don't only rely on these two. So I always look at the structural images, and I supplement it by the spectroscopy and the perfusion. But I think the structural images are, as you said, very important. Can I ask you, Dr. Ehab,
yes,
what do you do? Do you go for single voxel or spectroscopic imaging? What is your preference? You are one of the leaders in the field.
Always I'm using multivox. I begin with the sequence of the multivoxel.
Yes.
Because to be able to visualize multiple areas of the tumor as well as the peritumoral area. Yes. If I'm using single voxel, I'll pass all my time, all my day to visualize part of the tumor and then the peritumoral area. So I have to repeat the sequence many times. This is one thing. Whether to begin with the 3D multivoxel or 2D multivoxel, this depends upon the size of the tumor. If the size of tumor is very huge, I'll begin with the 3D from the beginning. If I can engulf it in a single sequence, so that I'll use the 2D.
And how long is then your protocol?
In fact, my protocol is that of the brain, a normal brain, the 3 axial, the SW, the diffusion, and the MP range or 3DT1. And then I'll do the spectroscopy and the same injection of contrast for the perfusion. So that it will take for that protocol about 40 minutes, 42, 43 minutes, which I think is acceptable for that cases.
Yes, I agree. Can I ask another question, Dr. Rashad?
Yes, go ahead.
Yes. So, Dr. Ehab, you are one of the leaders in spectroscopy. When do you not do spectroscopy, or do you always do spectroscopy?
No, I'm in the beginning. In the year 2010, 2011, I used to do spectroscopy. I investigated time and money to do spectroscopy for
every patient.
Yeah, any brain lesion. I wanted to learn. I wanted to build my learning curve. But now most of the cases that are coming, that's whether to differentiate radiation necrosis from recurrence, or there is a lesion which is ill-defined and we want to really know whether it is a neoplasm, yes or no. At some time, and rarely we can use it for epilepsy when there are the two hippocampi are affected. And we really want to prove that both hippocampi are really affected. Or in cases, in the early days, we were using this for cases of Alzheimer. to prove that the area of the cingulate gyrus and the splenium of the corpus callosum, we're showing decreased NAA value. But nowadays we are using PET-CT as an alternative for spectroscopy.
Or Alzheimer.
Yes.
Professor Ihab, I have a question from the panel.
Yeah.
I think perfusion-weighted imaging can solve most of the clinical scenarios in a short time, unlike MR spectroscopy, which is not usually ideal for agitated patients.
In fact, I have worked a lot with diffusion and tried to solve many problems. Example, to solve the problem of radiation necrosis versus spectroscopy. We found that if I have
Versus tumor.
ADC value more than 1.4, it is usually radiation necrosis. And if we have ADC value less than 1, it is usually occurrence. But the gap between 1 and 1.4 is very vast. And you can see multiple lesions between 1 and 1.4. So that if diffusion can solve some of the problem, it will the majority of the problems can be solved by combination of spectroscopy, diffusion, and perfusion. Perfusion may be of help, but sometimes if the patient has angiogenetic treatment, the lesion will be hypoperfused in spite that it is a recurrence. And in this condition, the spectroscopy will help to confirm that it is a recurrence, not just a pseudo response.
Another question, Dr. Ihab.
Yes.
Is spectroscopy more difficult to perform than a simple MRI?
Oh, everything has to be learned. No, I don't think it's more
difficult for the patient.
Yeah, no, it's just 10 minutes more.
Yeah.
But I mean that it is a little bit complicated from the technical point of view with the technician to do it. He must learn it quite, and it is not a simple sequence. But I mean, at the end, after just performing 4 or 5 cases, I think that performing spectroscopy is not a great deal. I have a question for Dr. Tariq, if you please.
Yes, go ahead.
Dr. Tariq, I think that what we see in autoimmune encephalitis now opened the domain for, I mean, very vast differential diagnosis list, especially if we put again this autoimmune encephalitis, not especially limbic, but even associated example with systemic lupus. We can see autoimmune encephalitis. I mean that now it seems to be that every case that we don't reach a diagnosis, we can put in the shadow, is it autoimmune encephalitis? And I think that it's a question that it's always projects when we don't reach the diagnosis to ask, is this autoimmune encephalitis?
I think you, of course, you have a point, Dr. Ihab. It's broad. So what it needs really, well, first it has exploded. No, it happens much more, or we are aware much more about it, and we have found many more antibodies. So it depends on the local environment and depends on the quality of request. We come back to the request you're getting. Are they giving you enough information, or are they just saying in the request, do brain MR? If they do brain MR, then
that's what's happening.
That's what happens. So, but if it is a neurologist, and you are on the phone and you can ask him, or ask her, well, how is the patient presenting, what's going on, and so on. What we have to avoid is to give a list of 20 differential diagnoses, because then the neurologist will say, well, what is it? I can do the same. I don't need this. But we can only improve in collaboration with the neurologist. So, you are right. How do I know? I need to know whether the patient has an encephalopathy or not. If I don't know it, it's one of the main things to know to get into diagnosis. Does the patient have a psychosis or not? And it is complex, like spectroscopy. It is complex. Yeah.
Thank Thank you.
No, I agree with you. It's just emphasis the need to closely work together with the neurologists and the neurosurgeons, and to have a personal relationship, ideally, so that they don't get angry when we ask them, and
In
they
the
know this
beginning,
is about.
in the beginning, it occurs like this, but
Yes, always.
after they understand the situation, they
Trusting.
will be very cooperative.
Yes, exactly. So when they understand it's not about power, but it is about improving the report, then they are willing to give us the information and talk to us and so on. But I think that is critical. And also
Exactly.
then you can think like you do, Professor Heb, whether they do whether one does spectroscopy or one does perfusion. By the way, I wanted to ask you, what kind of perfusion do you tend to do?
I have tried my T2 star
T2
perfusion
star,
at the beginning,
yes.
yes, and this was the standard. I tried after a couple of years to use the T1 and to use the K-trans, but I didn't. With the T2 perfusion, we can reach some cutoff values. These cutoff values are not 100% accurate or 100% sensitive, but at least at more than 80 or 85% sensitive. But the K-trans, I failed totally to have a reasonable range to judge about it. So
Yes.
each case by each, I'd like perhaps you have tried this T1.
Yes. So we usually do the T2 star. That's our main thing. And we have, because you can do a million sequences, no? So
Yes.
we do the DCE in those patients where we have blood, where there's a concern that the blood will affect the
Yes,
T2 star
exactly.
perfusion.
Yes.
Yes. Then we do that. We haven't been doing ASL because the ASL gives us limited information, but at the moment we are trying it on a limited number of patients. But our main thing is, as you said, is the T2 star, and on some occasions the T1.
I'm doing the ASL as a routine also, but with it will take 1.5 minutes only.
Yes.
And in many cases where there is degradation of the T2 perfusion because there is blood or calcification, when I cannot elicit the enhancement or the loss of signal, I mean, the ASL is working.
Yes.
And in few of the cases where I couldn't inject, also the ASL, I could rely on it for these few cases.
So I think you're right. So we are using it. We will use it now. I mean, we could have used it all the time, but I'm very strict because we have quite a big backlog about when to use what and how will it change the management. So with the ESL, the disadvantage is we only get CBF when we don't get CBV. So there is now a program from a company that will try to turn the CBF and give us also a CBV. They're working on this.
This is a good news.
Yes, so that's a company from Nottingham. They are trying to CE marking it because we are constrained. We can only apply techniques on patients if they have been CE marked. So this will come and will help. But in the meantime, we will be using it for those patients. It's very rare that they can't get gadolinium or they have reactions to gadolinium. And as you said, if there is a problem with blood. However, we are using it for non-tumors. We're using it for AVMs after gamma knife. Because of the blood flow, we have seen, and my colleague and friend, I mentioned him, Rolf Jäger, he has published that you can use it to see the flow if there is residual flow. So you would not need to do a DSA. So our workup now would be for an AVM, which has been treated by gamma knife, for instance, to do the follow-up by ASL. And if the ASL is negative, we will, of course, not rely on it, but then we will do the DSA. We will not do the DSA before. So that we will do the DSA to see, if the gamma knife has failed, if the irradiation has failed. So this
is a very important
indication
that I didn't know before for the ASL. I try to use it.
Yes, I can send you the paper from my colleague. Yeah.
Yes, we have always problem with those patients with the gamma knife. because they are suspecting that we'll tell in the report that everything is great. And I have never seen until now that the tumor has shrunk. I rely on enhancement. Perhaps there is little enhancement, but actually speaking, practically speaking, I have never seen changes in the size.
Yes. So this is, of course,
in the ASL, do you suspect any? I know that in AVM only.
Yes.
In the tumor, do you suspect any change in the perfusion after gamma knife? I didn't think about that.
No, I think it decreases. I think that decreases if it was high. But
perhaps we can search at this point.
Yes, we can look at this.
Yes.
But we use it. We will use it for AVMs, not necessarily for follow-up of tumors. Yes.
Okay. But it's a new domain. I think that it's deserves to be.
I have a new question.
Yes.
And it's for both speakers. Is it routine to have all of these AV panels once we suspect paraneoplastic syndrome? I.e., is it easier to start searching for tumor on the AVS, which is more practical?
If I start, if I start, it really happens in parallel. So the patient is often in the hospital, or he may be outpatient, and then the neurologist will ask for everything. He will ask for NMR, and he will ask for the antibodies. If the antibodies are known, then of course we need to look at the whole picture. And the whole picture, we have the advantage, we discuss it in a multidisciplinary team meeting. And then you put together the information of the antibodies and of the imaging. But I think the antibodies are here more important. Because the antibodies will can easier determine the diagnosis. Like in the case of, I'm moving away from tumors, from NMO, pneumonitis optica spectrum disorders, where you need to find the aquaporin, or the MOG disease, which also had the MOG antibodies. So the diagnosis is made by finding those. And similar in paraneoplastic syndrome, if I have a WHO antibody, or if I have a NMRDA antibody, the chances are quite high. They're not 100%. So at the end, it's a jigsaw. You need to put everything together. I hope that answers the question. I'll check.
It seems we chose good speakers, because there's another question. If the patient has known primary tumor, has no known primary tumor, is it paraneoplastic versus non-neoplastic, or is there a way to narrow down the differential?
No, I suggest.
I think that I mean that if we find that the brain is normal, as Professor Tarek said, it may be an autoimmune encephalitis with the normal brain. While if we find an abnormal brain, there is a mass or something like this, we can proceed with the advanced techniques.
Yes. And so when he says, do I suggest it's paraneoplastic? I don't think your suggestion depends on whether they have a tumor or not, whether the tumor is known. Because I said quite often the patient presents first with a paraneoplastic and no tumor is known. And then the tumor is identified in a high percentage within 2 years, and in 5 years, 90% have been identified. So you can raise the suspicion. So paraneoplastic, if you say paraneoplastic, it will always make the neurologist think about this. And you can raise that if you have the typical picture of a limbic encephalitis. But if you don't have the typical picture, it becomes complicated. It becomes like Dr. Ehab said earlier, there's a wide differential there. But if you have the high signal in the hippocampus, enhancement, and in other cortical areas, then that would fit quite well. And you would think about limbic encephalitis. This is your diagnosis. Limbic encephalitis can be paraneoplastic. And then they need to do the antibodies. And if they find them, then they need to do all the thing. And they will do whole body CT and MR. And then if they don't find anything, like in this patient, they do PET CT. And then if they don't find anything, they'll repeat it again, maybe in 6 months or 12 months.
Another question to Professor Tarek. Can I ask Professor Tarek about the role of diffusion MRI in multiple sclerosis?
Yes. Okay, so this is a classic question.
This is your field,
Yes.
baby.
There are two answers of this. The first thing is that in the criteria, the McDonald criteria, diffusion changes are not being used as sign of as part of making the diagnosis. Okay, so that's one thing. Now, the second thing about the follow-up, again, the MS criteria, this is the official. The MS criteria do not include changes in diffusion because new lesions can show restriction, may not show restriction, can be T2 shine through, so it was seen as being all very complicated. However, I have been exposed to patients, not mine, because I don't do diffusion. On the follow-up, I only do the diffusion for PML, so for patient who got a specific drug, which is natalizumab or Tysabri. So if, for instance, I had a colleague from South Africa who told me I found a lesion, and it was restricted. I said, yes, well then it's a sign that it's being, it's a fresh lesion. But officially we're not using it. We're not substituting gadolinium by diffusion. And in my world, if you think about it, what is the neurologist asking you? He asks you first whether you think this is compatible with MS, in which case you need to show dissemination in space, dissemination in time. Dissemination in space, you don't need it. Dissemination in time, you have the option either to show it by CSF positive, gadolinium enhancement, or you make a new MR and you show a new lesion on T2. This is the only area where it could be interesting if all the lesions are, T2 shine through not shown, and you have a restricted diffusion, then this could be, but it's not accepted as criteria. Okay. On the follow-up, you don't need anything. On the follow-up, you just need to show new lesions. The only thing that changes the treatment or the management is to show new lesions, not whether they enhance or diffusion or anything. So just to have we use the 3D flare. I'm sure you can do the same depending on your scanner. If you have, after 6 months, a new lesion, then maybe the neurologist will change the treatment. I don't know, Dr. Ehab, you're also working.
There is always debate whether diffusion restriction denotes activity, yes or no.
Yes.
Some of my colleagues say that yes, it must be, if it is restricted, it must be active. But until now, I resist to use diffusion restriction as an indicator of activity. It's restricted, full point, full stop.
Yes.
I don't rely for activity for that. I'm relying on contrast administration.
Yes.
We have a message from the president of the Egyptian Society of Neuroradiology, Professor Tariq, and he says that he thanks us for an excellent presentation and for interesting subjects.
Thank you very much. That's very kind of him. Thank you very much, Dr. Tariq.
Thank you, Dr. Tariq Dayasti, for you this kind comment. Thank you very much.
Thank you very much.
That closes this session, or?
So no further questions?
No more questions. Yes. Okay. I thank you, Dr. Tari Yusri. I was pleased to be with you in the same panel. I thank you, Dr. Rashad. I thank you, organizing committee, and for, I think, future meetings, live meetings together in Egypt.
Inshallah. I'm looking very much forward. It was a great pleasure to be with all of you, and I'm delighted that everything worked so well from a technical. So thank you very much to the technical team, and thank you very much for this. And from cold London to warm Egypt, my warmest regards.
Thank you very much.
Thank you. No.
Ma salama. Ma salama.
Ma salama. Ma salama.